Hi there, I'm going to use this pillow as my patient once again. So immediately I can see if the scene is safe for myself and my partner. We have BSI. It looks like I have one patient. No need for additional resources or apparatuses at this time. It looks like the weather is clear. I don't see any bystanders from whom I can get a sample history. And let's say that right now I see a 20-year-old male moving, sitting up next to a rock wall. So that's my general impression right there. So because of, let's say dispatch told us that he fell from a 4-foot rock wall, I'm going to immediately have my partner take C-spine because of the mechanism of injury. And at this time, I'm going to check if he's alert. So I'm going to say, hi there, can you tell me what happened today? Can you tell me what why you called 911? And he's going to respond, let's say that it's because of his leg pain. So immediately I know that he's alert and I now have his chief complaint. I'm going to assess the ABCs. So right now I can hear that he is breathing. I'm going to assess the quality, rate, and rhythm of that and write that down. So I'm going to have him open up his mouth. Using my pen light, I can see if the airway is clear right now. No need to suction anything. I'm going to look for any JVD or tracheal deviation on his neck that might imply a problem with his breathing. Everything looks fine right now. I'm going to expose his chest to see if there's any trauma that would interfere with breathing. Right now his chest looks fine, it looks intact. I'm going to check the pulse of this patient. So first the central pulse, then the peripheral pulse. Okay, let's say if they're both normal, strong pulses. I'm going to write down the quality and the rate of these pulses. I'm going to look at the skin of this patient. So right now it looks pink, warm, and dry, so that doesn't indicate any problems with the circulation so far. I have my gloves on, and I'm going to go down the body of this patient. I'm not seeing any blood on my hands as I go down. No blood on my gloves. So right now I'm going to say this is a medium priority patient given the mechanism of injury. I'm going to have my partner get the longboard and a collar. And in the meantime, I'm going to begin my primary assessment of this patient. So starting at the head, checking for any decap VTLS. I don't feel anything at this time. I'm going to see if there's any change in the JVD or any tracheal deviation at this point. I don't see anything at this time. I'm going to assess the shoulders, so I'm going to assess them one at a time, and then together. They seem intact. I'm going to press down on the sternum. The sternum feels intact. The chest walls also feel intact. I'm going to look for equal expansion of the chest as the patient breathes. It looks like it's expanding fine. I'm going to take out my stethoscope, listening to the lung sounds. Right now they sound even and clear. I'm going to now assess the abdomen, so I'm going to press down like this. Okay, so I feel a little bit of guarding on this left side. I'm going to make a note of that because that could imply some kind of internal bleeding, so just internal bleeding. I'm now going to push down on the pelvis. Okay, so when I push down on the pelvis, I don't feel any deformities or crepitus, but the patient does wince and complain of pain on the left side of the pelvis. I'm going to make a note of that to ask when I get the history from this patient. So now I'm going to palpate the rest of the leg, keeping in mind that he did have pain in the left side. So he does wince when I palpate the leg. Okay, the right leg, no pain. I don't see any major deformities so far. I'm going to grab some distal pulses. They are even right now. They're present, and they're matching the central and peripheral pulses that we got before. I'm going to now expose the arms. I don't see any major deformities. Checking the pulses. Okay, the pulses are present in both arms still. Now I'm going to have somebody still holding C-spine while we roll the patient over. I'm going to have more than one person doing this, hopefully. We're going to check the posterior side. So right now I don't see any irregularities to the spine. As I palpate, I don't see any irregularities to this entire posterior side. So we'll roll him back down. So I'm going to say that this is a medium priority patient. Oh, I'm sorry. So now that we have completed the primary assessment, we're going to get a sample history. So I'm going to ask him about the signs and symptoms. And I'm going to say, so I know that you had problems with your leg, and it looks like you also have problems with your pelvis. Are there any other issues that you're having right now? So he says no. I'm going to ask him about some OPQRST questions about these pains. So I'm going to start with the leg. So when did this begin? Probably when he fell off of the wall. I'm going to ask if there's anything that makes it better or worse. Like when I palpate, how much worse does that make the pain? I'm going to ask him about the quality of this pain. Does it feel like it's like a tearing pain or a crushing pain? I'm going to ask him about the region. So does it hurt up here, down here, just in the central region? Is it like a radiating type of pain? I'm going to ask him to scale the pain from 0 to 10 to see how painful it is for this patient. And I'm going to ask him if it's been getting better or worse or just mostly the same since he's fallen off of the wall. And then I'm going to do the same thing for the pain in the pelvis. I'm going to ask him when it began, was it just when he fell off of the wall, or was this a problem that we saw earlier? I'm going to see if when I palpate, does that make it worse or better? Like, what does make it worse? What does make it better? I'm going to ask him what kind of pain this is, so if this is a crushing pain, tearing pain like before. I'm going to ask him if it's just in this region or if it seems to be radiating. I'm going to ask him to scale the pain from 0 to 10. And then I'm going to ask him if it's been getting better or worse or mostly the same since he's fallen from the wall. And then I can, now that I've gotten some information about the two symptoms that he has, I'm going to continue with my sample history. So do you have any allergies? Does not sound like he has any allergies. Do you take any medications? Okay, let's say that he takes an antidepressant. I'm going to ask him about his past medical history. So do you have any past medical history that might relate to why you fell? Does not sound like he does. I'm going to ask him if he has any, what the last thing that he ate was. So it sounds like he's eaten breakfast. And about the events leading up to this. So once again, he clarifies that this is just, he lost his bearings when he was up on the wall. Let's say he was doing some construction, maybe nailing something into a tree. He lost his bearings and he slipped and he fell down onto the ground. And let's say that he fell on his side, on his left side. That would explain the leg problems as well. And he we make sure that he was not unconscious when he fell. This isn't like a medical history that then presents as a trauma. He simply just lost his bearings and fell to the ground. So now we're going to begin the transport of this patient. So I'm going to have, again, somebody, he's already got his collar on, thanks to one of my partners. Now we're going to roll him up, place the backboard down, roll him back down, strap him up. We're going to put him into the stretcher, and then we're going to begin transport. So now I can perform a detailed physical exam, again starting up here at the head. So I don't feel any differences to DCAT BTLS. I'm using my pen light to make sure that the eyes are pearl. Yep, they're reacting to light appropriately. They're expanding evenly. That all looks good. No major issues with the nasal bones right now. I'm going to look at the ears with my pen light to see if there's any fluid, bleeding, or bruising. I'm going to look at his neck, see if there's any JVD, any tracheal deviations, a stoma, maybe a medical alert necklace. So I don't see anything at this time. I'm going to now press down on his shoulders a little bit more thoroughly than I was doing before, really checking the clavicle. So right now the shoulders still seem intact. I'm going to push down on the chest. The chest is still intact. I'm going to take my lung sounds one more time. I'll probably be doing them more as I reassess as well, though. So I'm taking the lung sounds. They're still even and present and clear. I am going to reassess the abdomen. So I still feel guarding on that left side, so I'm going to make a note of that. I'm going to reassess the pelvis. So the patient, because the pelvis hurts, I'm going to be a little bit lighter on this side, but the patient still explains that the pain has not changed at all. I'm going to go down the legs. So there's no deformities to either of these legs, although there is pain. So we're still making a note of that. We can't treat for a fracture quite yet, but there is no harm in having one of my partners maybe splint it just for now, just in case, because we don't have an x-ray with us. I am going to recheck the distal pulses. So they're both present and they're both matching the previous pulses. That's good. This is especially important if we're splinting the leg. I'm going to assess the arms once again. So really getting very thorough with it, checking the distal pulses, making sure the CSMs are intact, so can he squeeze my hand, etc. Then down this arm, taking the pulse again, making sure that the CSMs are intact. I'm going to check for tenting with the dehydration, or dehydration with tenting. Skin still looks fine, and I'm going to reassess this patient every 5 minutes.